So we have I'll go through some of the major things that we need to go through at the beginning, and then we will get into this specific presentation. So welcome everyone again. We are sustaining primary care during COVID-19 track. And basically the idea is, although we have COVID-19 at hand, but then it should not interfere with our current primary care health system that we have in Africa, different parts of Africa. And what do we do in order to sustain the existing facility? What do we do such that that facility doesn't get dysfunctional? The judging criteria, just going over them briefly: impact, innovation, implementation, and presentation. So just be mindful of that. You were aware of this from day one. I just wanted to underscore that once again. Our judges, we have an amazing set of judges for this track. And I would ask our judges to give their brief introductions as that our participants know who they are. Starting from left, Abebe, could you go first, please?
Thank you. My name is Abebe. I'm a surgeon, a thoracic and general surgeon, currently Dean of the Universal Growth Equity in Rwanda. Thank you.
Professor Haas?
Hello, everybody. I'm Ifwa Hesse, Professor of Pediatric Surgery and President of the Accra College of Medicine, a private medical school in Accra, Ghana.
Salome?
Okay. Salome Maswime. I'm an obstetrician and gynecologist at the University of Cape Town. I'm the head of global surgery. Thanks.
Thank you. Last but not least, Dina.
Hi, everyone. I'm Dina. I'm the executive director at the Legatum Center for Development and Entrepreneurship at MIT, and I'm from Egypt.
So we welcome all our judges and thank them for taking the time to review the work that our teams have put together over the last 2 days. Going through the logistics. So just to know that this presentation is getting recorded. So your voice, and in case you turn on your camera, if we have the bandwidth later, that is going to be recorded. One member of the team is going to present. So it's going to be only one person speaking through the entire 3 minutes of presentation. Total, we have 5 minutes per team. I'm going to time you 3 minutes to present and 2 minutes for Q&A, and we move on to the next team. Ori will look into the speaker's hand, like who is raising the hand from the next team, and is going to unmute that particular person, and then that person can speak. Hope that is clear with everyone. And I think that is it. I am going to shout out because the video is probably having an issue here. So I'm going to shout out exactly after 2 minutes, that 1 minute pending, or just 1 minute. Hear that out. That basically means you need to speed up and finish your pitch. Overall, for this track, we have 3 winners, and that's true for all the tracks. We have 10 tracks together. So judges will pick the top 3 based on the judging criteria that you were aware of that I presented before. Okay. Moving on. So this is what happens. You raise your hand as if you're the next team presenting, host will ask you to unmute, or host will unmute you, and then you have 3 minutes to present, 2 minutes for Q&A. So team E11, you are presenting first, and the next team that is going to present is team E35, primary care. You can see, so this is how you will see each slide. You know the top name is the team which is presenting now, and coming up will be the team which is going to present next. So the speaker from that team should raise the hand for Ari to unmute you. Hope the instructions.
Question about how to raise hands. Can you just go over that quickly?
Yeah, so in order to raise hands, you need to, where is that? I think I can't see it here, but I think I think you can see that only in the participant tab.
Yeah. If you go under to the participant tab, where it says participants and you see the number, there should be an option to raise hand. If you don't see that, let us know.
Okay, see here, I'm going to the participant manage in participant tab, and over there, if you, I mean, I think it is in the participant tab. See, this is how you raise hand. Emily is raising hand and Phil, I guess, is raising hand. See this blue colored symbol. If not, you can, that particular person can just speak up and just unmute yourself and speak up. I think that works as well in case this is challenging. Hope that helps. Okay, so team E11, are you ready? Who is going to present?
Emily, I've raised my hand.
Okay, Emily, got you. So I'm going to start timing now. Emily, one more thing. What I can do is I can try to give you remote control such that you can connect your slides and like you can control your side. Can you do that? Can you try and see? Works?
Yes, it works.
Okay. So I'm going to time you now. Your time for 2 minutes starts now.
Hi, everyone. My name is Emily, and on behalf of my team, I'm here to tell you about our idea to improve maternal health and birth outcomes during the COVID-19 pandemic and beyond. So first, I'd like to introduce you to Amina. Amina is a 21-year-old. Sorry, I can't move the thing now. Amina is a 21-year-old woman living in rural community in Kano State in northern Nigeria. She's 8 months pregnant, but due to her fear around coronavirus and also reaching a clinic, she plans to give birth at home. She's at risk of becoming one of the over 100 Nigerian women that die during childbirth every day. So the problem here is that Nigeria has the second highest maternal mortality rate in the world, but that is partly because 40% of births in Nigeria are only 40% of births are attended by a skilled healthcare worker. This is because clinics are often inaccessible, quality of care is low, costs are very high, and there's often a lack of family support. We also know that maternal health care often falls during a pandemic. For example, during the Ebola outbreak in Liberia in 2014, access to prenatal care declined by half, and reported deliveries also fell by 1/3. So from this evidence, we know that the impact of COVID-19 on maternal health is going to be very substantial. So how can we address this problem? What we know is that what is needed, pregnant women need access and improved avenues to care and support during and after delivery in order to curb maternal mortality that will be exacerbated by coronavirus. How can we address this? We propose a two-pronged solution. The first aspect is that we would like to create an application to register pregnant women and connect them to existing healthcare providers and networks for monitoring and support. This platform would essentially classify a woman's risk level, allowing for a proper allocation of time, resources, and support according to the woman's risk and need. This would be supplemented by a care group model in which a care champion would form and maintain a community of support and connection for women who don't have access to smartphones. We do recognize accessibility is an issue, and we believe this will address that problem.
1 minute.
Thank you. The expected impact of our solution is that it will reduce maternal mortality significantly by creating a community of support and connection to care for pregnant women in rural Nigeria. The implementation is also very important here. This is a high-level overview of our solution. As you can see, it allows for facilitation of communication between pregnant women and care champions and the existing healthcare system. It is flexible and adaptable and sustainable even after COVID-19. The implementation, we hope to use existing food distribution systems. Currently, the government of Nigeria and NGOs have food distribution sites. We will have community care workers there to register women on the app. We will also hope to partner with existing organizations, both maternal health care organizations and existing applications that seek to connect pregnant women. We hope to work with them as we roll out so that we can develop a sustainable system going forward.
Time up.
Thank you very much.
Judges, you have 2 minutes for Q&A.
Yeah, I have a question. Thank you, Emily, for that. and I'm sure you guys worked really hard on that over the past couple of days. I guess my question is, two questions. One, are there enough healthcare workers to support pregnant women in Nigeria, specifically in remote areas? And how, I think you moved really fast, but I wasn't sure, would the healthcare workers work with these women via technology, or would they be able to actually physically be with them?
So I can take the first part of that, which is that we do recognize there's a severe shortage of skilled healthcare workers. So we are actually proposing this system as a solution to help allocate the scarce resources where the need is greatest. And then to the second part of your question, Aisha, are you there?
Yes, I'm here. Can you hear me?
Yes.
Yeah. Okay, so for the second part of the question, how we're going to make
Aisha, your voice is cracking.
health workers that are community extension health workers in Nigeria across every community. So what we do is reach out to these women through government.
Aisha, your voice is cracking.
What we do is reach out to these community health extension workers that exist in all communities in Nigeria through the established health system or through an NGO that has support structures for health workers.
Okay,
and then we link up with them and liaise, give them ideas. We might be able to support with smartphones for each true health worker.
Time up. Sorry, we need to move to the next team. Time up. Sorry, we have to move to the next team, but thank you. Great presentation, team. And so we have to, in the interest of time, we have to just move to the next team.
Wait, let's give the judges just a minute to fill their forms.
Yeah, definitely.
Yeah. Judges, if you need the form link, let me know. I'll send it to you.
So I'm Phil. I'll be next. I don't know if I can get the remote control.
Can you just tell me your name, please?
Phil, and I have raised my hand.
Phil?
Yeah. Purple icon. And I raised my hand so you can find
So just for information, I think Emily was mentioning that there is a lag between you clicking and the screen going to the next one or slide moving to the next slide. So just be mindful of that, and if required, like click a little earlier. It's okay.
Can you give me the remote control again? I think I missed the...
No, you have
to acknowledge.
We're controlling it now. You are controlling it now.
Okay.
Okay, I think we should start. Do you want to go back to your main slide?
Yeah, so you can go back. Maybe you do it. It'll be easier with you doing it.
Got you.
All right.
So your time starts now.
All right. So our project is called Primary Care Safe Zones. These are the people involved. Next slide. And our project is to separate separate primary care and COVID testing and treatment, so that there is no cross-contamination between the two. That's a problem that we've seen that is relatively easy to address, but that we've seen some situations where it's not being addressed, and it's putting in danger, is putting at risk the patients from both sides, the primary care seekers and the COVID patients. There's a huge risk of unnecessary spread of COVID this way, and of contaminating COVID patients with other diseases that would put them at higher risk of mortality. Next slide. Next slide. Yeah, so our solution is actually very simple and easy and very cheap to implement, is just to set up geographically separated centers for primary care or for COVID to externalize them from the building in which the healthcare building that are currently in place. So either with a tent, as you can see in the picture, or using other government-owned buildings such as schools or gyms. And the one trick is to call these a green zone and a red zone, and to avoid the contact between the workers and the staff working in the two areas. Even encouraging them to stay, to not even meet socially, so to avoid contamination between the two. Our solution involves, we can maybe go to the next slide, communicating the addresses of these different centers to the population through SMS, mass SMS sent by the government telling people where to go if they have COVID or suspect that they have it, and telling them not to go to primary care centers or hospitals where they're at risk of infecting people. You can go to the next slide. Yeah, so this is just the takeaway message. These are 3 bullet points. The important thing is to separate the COVID patients from the ones needing primary care, and geographically separated different buildings. So that's it. And Gary will take the question since he's at the origin of the idea.
Judges?
Okay. My question is, you haven't spoken at all about the asymptomatic patients. And I think that's where the danger zone is, because naturally, there's a bit of a separation between the two, except from the ones that haven't been tested yet.
Gary, do you want to take that?
Well, yeah. Hi, I'm...
No, I think Gary needs to...
Infection, maybe COVID, or it may not be. If they can be separated so that primary care services can continue.
Well, 1 second, Gary. So just to explain, Gary's on a landline because he can't be on here. So I'm relaying it into my microphone. So do you want to go ahead, Gary?
Yeah. Okay. I think the question.
Sorry.
I think, Phil, you should try to give a brief summary. I mean, it may be difficult.
So I can, okay, Gary, do you want to say it to me and I'll repeat it? So the idea is to separate the potentially infected patients to reduce collateral damage. Yeah, the collateral damage that there would be from people lacking primary care. Does that answer the question?
Not really, but that's okay.
Sorry. Yeah, sorry, it's quite hard to relay. Are there more questions?
Okay, I think we can move probably to the next team. Thank you, team, for the presentation.
Okay, thank you.
So next team is Quick Health Info, who is presenting now, and following that will be Empower Last Line. Who is presenting from Quick Health Info? In the meantime,
it's
judges
myself.
can fill out. Casey?
Cassie.
Okay, Cassie.
Can I share my screen?
No, I think I've been sharing it. You need to, I can give you control. Is it Casey Uddo?
Yes, Cassie Udo.
Okay. Now you can control the screen. Can you?
Let me see. No, I can't.
Is Pratham on your team?
I'm sorry?
Is Pratham on your team? Pratham?
No.
Okay, so in that case, I think you just tell me when I have to move slide, and then I can control the slide for you.
Okay.
So judges ready? We should start. Can we start with this team?
Yes, we can. Please
I'm
go ahead.
ready.
Yes.
Thank you. Okay, Casey, your 3 minutes starts now.
Okay, so thank you everyone for giving us this opportunity to help fight COVID-19 in Africa. Our passion and motivation beckons us to give back with the solution we are currently building. What we find today is that most communities are not going to health centers due to this pandemic. We have to make access to these health centers safe and easy, and let members of the community know about this. So this isn't the first slide. Who's controlling the slide, please? Yes. So this is Amina. This is Fatima. She's a typical farmer in sub-Saharan Africa, home to millions of people like her. She's 5 months pregnant and nursing a 1-year-old son, Abu. So ever since the onset of this pandemic, she hasn't visited her primary health care center and has therefore missed care for herself and for her son. Our goal is to address this fear and misinformation on both ends and maintain and drive patronages of these primary health centers. Next slide, please. And this is Ami. She's a community health worker and has the trust of members of her community like Fatima. So fortunately, she has been monitoring Fatima's missing appointments using our quick health info. She's able to track her by getting in touch with her, sending her details, factual information concerning COVID-19, dates of her appointments, and information on listed public health centers that are following due SOPs and listed on our platform. Next slide, please. Now, why are we using USD? It's a simple technology, has a wide coverage. It is home to over 90% of users in Africa. Next slide, please. So by utilizing this trust that Ami has with members of her community, we'll be able to educate these community health workers with our digital videos on how to use this our USSD platform. Next slide, please. Next slide. Now, this is our typical pathway of the simple USSD-based technology. It uses a simple SIM, so just dial the code. It prompts you on what language it uses, so either your local dialect or English.
1 minute.
And then what's healthcare that is needed at that moment. Next slide, please. So this is our strategy for the next 6 months, is to innovate from the USSD, perform a seamless transition from voice to text. And then this, please, previous slide. And then this platform is also scalable in that we can move it from USSD to smartphones, which are increasing in Africa at a rapid rate. Next slide, please. So this is a simple revenue model based on subscription and pay as you go. Next slide, please. And this is our next step: bring awareness, scale the business, test it, launch it, gather data, and then do an outreach to other geographical similar communities. And then by Q1 of next year, scale up to using AI-based platforms. Next slide.
Thank you. Thank you. Time up.
Thank you.
Judges.
Is your solution applicable to what we in Ghana term the YAM phones, the not modern phones? Is it applicable to them as well? And what's the extent of penetration in the area that this is going to be used in?
So, I'm not familiar with the YAM, but this is a simple USSD. So it just uses a basic Nokia 3310. Once you have a SIM card, this works. So the penetration is, we know that the majority of Africans, especially in rural communities, have access to the basic phones. So we're going to start from here because this is our target market. And then we'll test and function this idea of us. If it proves successful, then we scale up to using smartphones because the market for scaling up to smartphones exists in Africa. So we start with the impoverished communities first because we took into account equity in our innovation. I hope this answers your question.
For now, it will do.
Okay, thank you. Are there any other questions?
Yeah, I was just wondering, what other markets were you planning on scaling to?
So the market that we plan on scaling to is the smartphone user market. We're starting from the basic USSD. So it's the simple GSM that most members of rural communities use. And we know that over about between 30 to 45% of Africans have access to smartphones. So this market exists. So we hope to digitize this platform by moving over to AI technology and cloud and the rest, yes. So it's something that is scalable.
So time up, but thank you for the presentation, team. So we'll move on to our next team, Empower Last Line. Who is going to present?
I will be presenting.
Hello?
Hello?
Abigail?
Yes, I'll be presenting on behalf of my team.
We're not able to hear you clearly. Can you speak up a little? Speak louder.
Sorry, I'm saying I'll be presenting on behalf of my team.
Okay. So I'll control the slides for you. Just tell me next slide. I'll move on to the next slide. Your time starts now.
Okay. We are Project Empower Last Line, and our objective is extending the communal reach of the community health workers by cutting down the bureaucracy in the hierarchical framework of the current healthcare system. Next slide, please. Okay, so the problem that we've noted is bureaucracy in communication channels delays healthcare delivery at the primary healthcare level amidst the COVID-19 pandemic. This is especially evident in the ongoing CSM outbreak in Ghana. Next slide, please. This bureaucracy is even more evident in the coordination of vaccine delivery. For instance, once the community health worker has relayed the need to the contact at the healthcare facility, this information is then relayed to multiple offices before a team is dispatched. Hence, a lot of time is taken. Next slide, please. So for our solution, next slide, thank you. For our solution, we are proposing an application that will serve as a communication link between the community health workers and other health workers in the health facilities within the area. So using this app, it integrates all the health workers in the region. For instance, in our case here, if the community health worker is in need of an extra nurse in the field, using this app, they'll be able to relay that information to the nurse in charge instead of that information being relayed through multiple channels and saving time. The next slide, please. As you can see, using this diagram, the application will permit a feedback loop at the various levels. Next slide. We plan to implement this by training the community health workers and other health workers involved so that they're familiar with the usage of the application, and then also to collaborate with telecommunication companies in providing USSD code through which people can reach their community health worker and healthcare.
1 minute.
Sure. The next slide. So why is our idea better than the existing setup? It offers a more comprehensive and integrated approach. And then also, we plan to have this app linked to the health management information system. Therefore, it will allow data backup and also accountability. And also our app will serve as a disease surveillance tool. So what will be the cost of inaction if our idea is not taken forth? It will be poor disease surveillance, high risk in outbreak neglected diseases, and also an increase in morbidity. The next slide. So what next? We are planning on implementing and monitoring and also increasing the awareness about the community strategy approach at all levels and building commitments from government and partners to provide community health services.
Time up.
Thank you.
Thank you. Judges?
So just for clarity, is it two-way? It's the app the healthcare workers also have got access to the community healthcare workers, and the community has got USSD access to the community health workers.
Yes, using this application, it will be able to integrate all the healthcare workers at that region in that application. So facilitating communication among all health workers, so the access will be restricted to what's relevant to a particular health worker.
Does the system work offline, or does it always need internet connection?
Not really, because this system can also be used on mobile phones that are non-smartphones. So communication can also be done via SMS and then captured in that database.
What is the linkage with the referral systems?
I haven't understood the question quite well.
Did you envisage any linkages with any referral systems?
Robin, maybe you can help me on that.
So the focus we have is since the community health worker has access to whoever case they are taking, so they have also the option of referring any cases back to the health center, who will be better equipped to handle any issues that are beyond the capacity of the health worker on the field or who's attending to any case.
Okay, I think time is up, but thank you, team. Thank you for the presentation.
Thank you.
So now the presenter will be Team Challengers E006, and next would be Birthing Bridger.
Just give the judges 1 second to.
Yeah. Mentors, let us know, judges. Who is going to present from Team Challengers?
I am. It's Marty.
Marriott?
Yes.
Okay. I think I'll run the slides for you. So just tell me next slide and I'll move on.
Sure, no problem.
Just tell me slide. I mean, just use the word slide. I'll move on. Okay.
Okay. Can I start?
Judges, do we start now?
Yes, I'm ready.
I'm ready.
Okay. Marriott starts now.
Okay. I want you to imagine Peter. He's a 67-year-old male living in Johannesburg. He has been on treatment for HIV and hypertension for the past 2 years, during which time his medication has not changed. On the surface, he is healthy. However, we also know that due to his age and chronic comorbidities, he is at high risk of complications should he develop COVID-19. Through CCMDD, Peter's grandson collects his monthly medication at a grocery store close to his house on his behalf. However, he is due for his 6-monthly follow-up at the clinic soon, and he is scared, as he will need to take 2 taxis to get there and will not be able to practice appropriate social distancing throughout his journey. This, while the visit itself is unlikely to change the management of his disease. Slide. Our solution aims to help patients like Peter through existing infrastructure in the central pharmacy with a telehealth solution that enables contactless integration and eliminates the need to travel among vulnerable patients. Slide. Our product is called Text Collect, and it is based on a USSD platform. Today, patients like Peter need to travel to the clinic and see a doctor in person to have a script renewed or extended. Text Collect will allow patients to be assessed by answering simple questions on their cell phones that confirm that they are compliant and not experiencing danger signs of complications related to their illness, after which their healthcare facility can then approve the issuing of a new script remotely, reducing the need for consultation. Slide. How this works is that 2 weeks prior to a prescription expiring, a patient like Peter will receive an SMS prompt which will guide them through a series of questions tailored to their condition and in the language of their choosing. Based on answers, patients will be told to either go to the clinic or that the script has been extended, and they're notified when it is ready for collection. Slide. 26% of all South Africans above the age of 15 years take at least one medication regularly. Our target market is the 8 million South Africans that take at least one medication and is stable in the management thereof. We estimate that with 10% utilization, we'll be able to prevent 800,000 visits over a 6-month period. Sources of funding could be for clients, would be local government, foreign aid. We are initially focusing on South Africa, but we recognize that the problem is not limited to this setting and that the solution can be adapted to other settings. Our product will require an initial investment, Our product will require an initial investment of 1 million, and we will use a subscription-based fee. And even with conservative estimates, we have a projected to generate a return at year 2 slide. We hope to start implementing this by middle of July slide. What differentiates us is that we are leveraging current technology while preparing the health system for the future and are using artificial intelligence to improve the patient experience slide. So with $1 million, we can generate profit within 2 years while improving the health of millions slide. We have a diverse team of professionals that is hoping to move this forward. Thank you.
Thanks. Judges?
I just had a quick question. Thank you for that. What is the situation in South Africa now with regards to telemedicine? So is it actually not taking place? Does somebody absolutely have to go in to get a new prescription? Is what you're offering something completely new?
So my understanding is that telehealth is being offered in the private healthcare sector, but our solution is focused on the public healthcare sector where patients need to go into the clinic to have a script renewed, yes. So we're sort of hoping that our platform replaces that part of it.
Okay, thank you.
Okay, is there an interaction between the doctor and the patient, or is it just based on a questionnaire that they answer?
So there are different options for this. It can be without any contact, but the health clinic where the patient is registered gets notified of their interaction and the outcome based on the algorithm we've written. But then the patient at the end of their interaction with the tool also gets told, so based on the questionnaire, it's okay for you to continue with medication. And at the end of that screen, it says, are you happy to continue with the medication? Yes. Then there's also an option to say, yes, but I have questions about my healthcare, which will then connect them to a community healthcare worker, which can triage them to go to talk to a doctor. Or no, I still want to see my doctor, in which case the script will not be renewed and they can go to the local healthcare facility.
Okay, what percentage of the South African population would be able to access this facility?
So
the solution is targeting people that are underprivileged. And so these are the people that since we are using a USSD system that is cheap and it does not require any internet usage. So from the doctor side, they will be able to interact it through the system, through government systems that are already in existence.
Time up, but thank you. Thank you for the presentation. Great presentation, team.
Thank you.
So Birthing Bridge team, get ready for this presentation. And then the next team is Team Modular Health. Judges, I'll wait for just a confirmation from your side before the Birthing Bridge team starts pitching. Who is presenting from Birthing Bridge team?
Hi, Shavik, it's Megan. I'm going to present for our team.
Okay, Megan, yeah. So I'll just control the slides, same, just tell me slide, I'll move to the next one.
Okay, great, thank you.
Thank you. Judges, can we start?
I'm ready.
Yes.
Okay. Sorry. Megan, time starts now.
Hi everyone, today I want to talk to you about our idea of Birthing Bridge. Slide. Birthing Bridge is a platform aimed at mothers like Tondi, a 23-year-old expectant mother living in a densely populated township in South Africa and experiencing symptoms of preeclampsia. She does not want to go to her local clinic due to the current risks of COVID-19. She has young children at home and her other pregnancies have been fine. Slide. However, statistics are not in Tondi's favor. To help Tondi, we're trying to address the question, how can we sustain primary care in the setting of COVID-19 to continue the steady decline in maternal morbidity and mortality? Slide. Our solution was to develop Birthing Bridge, which empowers expectant mothers with the ability to self-monitor and self-triage in order to limit the number of primary care visits during COVID-19. Birthing Bridge encompasses a multi-pronged approach focused on a text and call platform that does not require a smartphone and uses information dissemination and a triage network. Slide. In the process outlined here, an expectant mother would contact Birthing Bridge via text or phone and be able to receive support in 3 different areas. She can receive scheduled text messages with pregnancy and COVID-19 information, request medical support through the help of our triage network, or receive community support from mothers in the local area. Slide. These example communications show on the left how a mother might interact with the Birthing Bridge system, and on the right how she might receive scheduled pregnancy and COVID-19 education. Next. Expectant mothers like Tondi can have better outcomes when utilizing Birthing Bridge. In Tondi's case, one of her regular Birthing Bridge text reminders included warning signs of preeclampsia, prompting her to contact Birthing Bridge's call center, where she was diagnosed with preeclampsia, directed to a clinic with medical history, and able to receive treatment, eventually delivering a healthy baby. Slide. Our business strategy focuses on utilization of existing and proven structures. For information dissemination, we will utilize existing community-based organizations and mHealth platforms. For the triage network, we will leverage existing community health workers, volunteers, and retired nurses.
1
And for
minute.
the text platform, we will partner with viable existing solutions that rely on text messages, which have a high rate of accessibility in countries such as South Africa. Slide. We hope to partner with organizations such as existing mHealth platforms and community leaders, and to obtain funding from organizations that have a vested interest in sustaining maternal health care during COVID-19. Slide. Birthing Bridge is a solution that can be implemented immediately to improve maternal care during COVID-19 and can also provide a longer-term solution to crowded and overstretched clinics. Slide. And we just want to say thank you to our fantastic team and mentors and open it up to the panel for questions.
Judges?
Yeah, thank you. Thank you so much. I have one question for you. The reason patients visit hospitals is to have their blood pressure taken and urine tested for proteins. How do you plan to have that done?
Yeah, so I'm actually going to turn this over to Margaret, one of our physicians on their project.
Hello, everyone. Can you hear me?
Yes.
Yes.
Okay, great. So among this, what we talked about, if you can go to the slide that has the breakdown, if the person starts experiencing, yes, thank you, they would get text messages, and if they were having any concerning features, they would be connected with medical support. So they would describe their symptoms. At that point in time, the staff would be able to take a history and see if it was concerning for any possible complications of preeclampsia. And if so, at that point in time, it would be a referral to a clinic. But it would be triage based upon their pregnancy, complications, and overall past medical history.
Thank you.
All right, but I think the question, I mean, just to add on that, because what about the patient that doesn't immediately have to go to hospital or doesn't have, you know, signs and symptoms of preeclampsia? Is the system going to make us miss patients that would have had to come to us? Or is it going to make patients come faster if they need to? Well, I think, are we making patients stop attending some of the antenatal sessions or not? What are you trying to achieve?
So what we're trying to achieve is bringing more people into antenatal appointments, as right now the fear is that they might contract COVID. So with Tattie's example, she feels overall well and her other pregnancies had been okay. And she's afraid of getting COVID-19 because she could expose her other children at home. However, when she's getting these primary care updates about COVID-19 and what a normal pregnancy is, she would be able to self-identify that she is having some concerning symptoms right now that could mean that she needs to go and be more urgently seen. Then she would call up to our platform where she would be triaged and routed to the appropriate level of care.
All right, thanks.
Okay, thank you, team. Great presentation. We'll now move on to the next team. Team Modular Health will be presenting now. We'll give a minute for the judges to fill up their forms. And HELIMA Health would be following Modular Health. Who from Modular Health is going to present?
That'll be me, Uzo.
Uzo, okay, awesome. Just again, same thing, just tell me slides. I'll move to the next one.
Sounds good.
Judges, should we start?
Yes.
Okay, Uzo, your time starts now.
All right, thank you guys for having us. We are Team Modular Health, and I am going to be presenting on modular healthcare delivery for primary care. Slide. The COVID-19 pandemic has led to a lockdown in most economies and has led to limited movement of people and disruption of traditional supply chains of goods and services. Slide. In Lagos, Nigeria, with a population of 21 million, this has restricted access to essential medical services for patients with chronic medical conditions and for children. Next slide. The three main pain points experienced by these groups are limited or no access to consultation, lack of access to lab services, and lack of access to essential medications. Next slide. Here is a pictorial depiction of all the touch points required to access care using a traditional model of delivery. Next slide. The implication of this problem, if left unsolved, is increased morbidity and mortality from preventable complications. Next slide, please. Next slide. So to solve for this problem, we propose deploying a management information system and leveraging strategic partnerships to deliver remote care. We coordinate the delivery of telemedicine consults and home delivery of test kits and essential medications to address those pain points highlighted. Next slide. Here's the future state flow depicting the improvements in service delivery from our services. Next slide. Our total addressable market is 5.2 million lives. Next slide. To evaluate our proposal further, we use the business model canvas framework. We differentiate ourselves through disrupting traditional care models by coordinating remote service delivery. And by leveraging our strategic partnerships, we provide unparalleled care. This also provides a plan of implementation for when we roll out our services. Next slide. We measure our success through reducing physical touch points to access care, through cost and time savings per episode of care, and through improvement in disability adjusted life years. Our goal is to reduce preventable mortality by 1,000 per 100K population per year. Next slide, please. Here are a number of our strategic partners who we've reached out to and who deliver essential medications and test kits to people's homes.
1 minute.
Next slide, please. A number of potential risks include data privacy issues and misdiagnosis. We aim to address this through effective security protocols and through follow-up of our patients. Next slide. Our projected revenue is $760,000 in 3 years with a startup cost of $150,000. Next slide. We are a team made up of experts across the medical and software engineering fields. Thank you so much and looking forward to your feedback and questions.
So,
great timing, team.
Quick question. My understanding in Nigeria is that the demand for healthcare is much higher than the supply of medical workers.
Yes.
So if everyone is trying to access what you're trying to provide, how will you be able to provide them with services with limited qualified people to provide diagnosis?
So the advantage of our platform is we actually try to solve for that because we have a very low medical provider to patient ratio in Nigeria. So the whole idea is to partner with health maintenance organizations which already have panels of patients and which already have providers that they work with. So our target audience and our target market for starters are people who have health insurance under the health maintenance organizations and under the government insurance plans. Through leveraging these panels, we can provide that remote care by leveraging the same providers that are networked with these health maintenance organizations. So where we reduce costs for these organizations is to provide the remote care so we don't have all patients coming physically to access care in the clinics. And that's even a good point now due to the COVID pandemic because of the shutdowns in most cities and because of the disruptions in movement of people to actually access care in physical locations. So the whole idea is to treat non-complicated cases remotely and then give the providers the time and the space to treat the more complicated cases that can come in physically to the clinics.
How many of the low-income people in Nigeria do you think would be able to access this service?
For now, I can't put a number to that, but what I can say is we have a very cheap health insurance plan provided by the government. The reach isn't as prevalent yet. I mean, we have about 11% of the population that has health insurance, either through their employers or through the government. For most of the people who have it through the government, it's a very cheaper form of health insurance, and they typically access care in the public health sectors. The problems these healthcare systems face is there's really no planning, so they have a lot of patients coming in to access care. And this puts a strain on resources, both personnel and equipment. So what we're trying to do is, for these low-income guys who have health insurance through the government, because it's subsidized by the government, we would provide this care to many of them remotely. So we can triage and prevent the non-complicated cases from coming into the public healthcare systems. Over time, seeing the financial sustainability of this, we plan to expand into other areas like the rural areas where we have low rates of health insurance and low incomes.
Thank you, Zo. Time up. Team have to move to the next one. Thank you.
Thank you.
So HELIMA Health will present now, followed by Med Diary. Med Diary, get ready. We'll give a moment for the judges to fill up their forms. And HELIMA, who is going to present from HELIMA Health?
Hi, I'm Sarah Covington. I'll be presenting for our team.
Awesome, Sarah. Again, the same thing, just slide and I'll move.
Excellent, thank you.
Ready.
Awesome.
Ready.
So, yeah, thank you. Sarah, take it away.
Hi, we're HELIMA Health. Slide. The local cities in the state of Oyo, Nigeria are not receiving the data-driven care they need during the pandemic, placing pregnant and chronic care patients at higher risk. This is a systematic problem that is reflected throughout Africa that needs a solution now and moving forward to improve patient outcomes. Some patients travel long distances directly to the secondary care facilities, while others forego care entirely as volume has dropped over 90%. Many primary health care centers are closed due to fear and a lack of PPE. These centers are integral to maintaining the trust that has been built thus far and should be the primary point of entry into the healthcare continuum. Slide. Our solution to improve clinical outcomes for this vulnerable population uses an SMS-based chatbot initiated by the trained community healthcare worker, overcoming the obstacle of closures from PPE limitations. About 70% of the intended population has a smartphone, which encompasses the 2.1 million target market. The chatbot engages the patient to download the app, which is powered by an existing AI-integrated product to conduct a scan. Primary healthcare centers can use the information from the scan to make evidence-based decisions during the telehealth visit and appropriately route patients to an on-site primary care facility, a secondary hospital, or to a pharmacy for their prescription. Slide. Let's check out how Adi used the technology to receive care from Dr. Yatundi. The patient engages with the chatbot to share their chief complaint. Evidence-based decision-making is key, and the app facilitates a scan powered by Bana leveraging AI to garner biomarker information that has been clinically tested for medical grade accuracy using effective computing. The data, coupled with machine learning, will provide predictive modeling and risk stratification. Using Echo AR, the app is embedded with 3D imagery, providing clinicians a tool for patient education. Slide.
1 minute.
The chatbot and telehealth solution are ready for production. The app is in the development stages as well as the analytics, which will provide a basis for benchmarking improvements in population health. Slide. Future integrations include the development of respiratory sounds monitoring, translation services, a medical drone to conduct scans for patients that do not have a smartphone, temperature readings, and continued predictive algorithms based on population symptomology. Slide. The funding for the service will stem from government sources, private healthcare, NGOs, and insurance companies, providing integral partnerships to receive the patient phone numbers needed to scale quickly. This project has the potential to be adapted to many markets and is constructed compliant with the MDCN, WHO, and in the future with the US market. Slide. The team has a diverse background and is ready to bring the product to life. What questions can we answer for you?
Judges?
No question.
Anyone else?
Thank you, everyone. It was a joy to get to be involved in this project. Our team is very excited and planning to continue working well after this weekend to implement this product.
Thank you, team. Thank you. Great presentation. We'll give judges a moment to just fill up their forms. Next team who's presenting now is Med Diary, followed by Vital Ranger. Get ready. Who is presenting from Med Diary?
I am. I raised my hand. The participants.
And nice.
Yes.
Okay, good luck. And
thank you. Let me know when we're ready to take it away.
Yeah. Judges, just let me know. Are you ready? Okay. Take it away. 3 minutes.
Thank you. Next slide. So 640 people died in Kano last week. Nobody knows what's killing people. Is it COVID? Is it something else? Now I know because my friend Peter lives in Kano. On a phone call 2 days ago, he told me he suspects he has malaria, but can't go to the hospital, of course, for fear of COVID-19. He represents 13.4 million people in Kano and a lot more around the world who can access regular healthcare during the COVID-19 pandemic. So how can we make sure Peter continues to get access to healthcare? How can we make sure healthcare workers get the data they need to effectively triage? Enter the solution, next slide. Med Diary helps health professionals diagnose, treat, and prevent medical conditions. Very simple USSD platform. Here's the idea. Patients registered via USSD, they put their location, put their names, and if they have any registered hospitals, fine. If not, the default is the primary health center closest to them. Patient log whatever they might want to tell the health professional, along with their perception of its severity level via USSD. If serious, the system shows them a toll-free number that routes to the health center closest to them. With the patient's consent, the hospital or care providers have access to the logs and they're actively monitoring it and gets additional notification when the severity level is above a certain threshold. For log reports that carry that threshold, care providers could call the patients to learn more, or otherwise make a decision on what next to do, either ask the patient to come in or go to the patient. After a diagnosis, caregivers attach a dated diagnostic summary to the patient's file, also via USSD. Now here's what the solution looks like. Next slide. It's very simple. It's accessible for everybody, and we're sure that it works for all phones anywhere in the world, no internet connection needed. Next slide. What we're solving for non-COVID-19 patients get access to needed healthcare. Healthcare workers get better data to continue to help patients from a distance and decide who to come in. Governments can keep a finger on the population's health pulse, and public health organizations can access anonymized data for more studies. How is the solution different? For patients, We're reducing trips to health centers. For community and governments, we're collecting data that could morph into an early warning detection system, right? And since it's USSD based, it can be used anywhere in the world, right? Even with roaming networks. Once implementation partnerships do we seek? Next slide. Now, governments dream to be part of an early warning, please next slide. Government dream to be part of an early warning detection system. That's why we know ministries of health and primary health centers will give us access to the patients they currently serve so that we can kick off with them. We've confirmed this by speaking to people in that sector. NGOs will love the reach we have and effectiveness, so they will help us raise awareness. Telcos will help us subsidize the US as a solution at scale. Thanks so much for listening. Looking forward to your feedback and questions.
How do you ensure
that tech,
of the data that goes into your system?
So somebody's writing on the screen. I don't know.
You know what this is, by the way?
How do I protect the data that is on our system?
Mm-hmm.
Yeah, so we're going to follow standard protocols to make sure that there are standard security protocols when handling, especially medical data. We'll make sure we're going to follow all protocols and to make sure we're hack-free. And also patients get to determine, like the patient gets to consent to the data or not if they choose to. Does that answer your question, Dinette?
No idea where that's coming from.
Yeah.
Can you
Have
just,
you started this implementation already?
So what did you say?
Have you started this program already?
No, we haven't. We're still in the product defining stage because we started this weekend. We're digging into the problem to define exactly what parts of it we wanted to focus on. I might just add that we've spoken to a few partners and we know exactly how we're to kick off once we leave here, literally, especially people in government.
This is Mambi, his teammate. If I can just add that there's a similar program in Lagos State right now, but they're using voice calling. And when we talked to private health practitioner, she said that, obviously one of the advantages of our system is, definitely collecting the data, having the records available for practitioners and then also for the government. So it is something that we would implement using existing infrastructure and the existing networks that are already available.
Yeah, I think we're out of time here with the team. Thank you so much for the presentation.
Yeah, thank you, Shuvik.
Also,
there's somebody
something
writing
on screen.
Yeah, we see that. We're going to try to address it by switching something.
Are you sharing now?
Yeah, I will.
Maybe try to stop screen share and restart it.
Yeah, that is what we are trying to. Are you sharing now?
Yes. Oh. Okay, can you see?
Yeah. Yeah, we can see. Let me try one thing. So you can just go ahead and you can change the screen. Just continue the same thing. I'll manage the participant window. So the next team we have is Vital Ranger, E17. I see many hands up there. Who is
available? I'm available.
Dr.
Can you
Elvis?
hear me?
Yeah,
Yeah.
Dr. Elvis, I can hear you. Yeah. Judges, are we ready?
I'm ready. Yep.
Okay. Dr. Elvis, your time starts now.
Okay. Good afternoon. I'm Elvis, and we are presenting Vital Ranger. It is a laser focus on hypertension and COVID-19. Next, please. Next. So hypertension is related both directly and indirectly to COVID-19. And like we've heard, pregnancy-induced hypertension is an indirect relationship. Then we have those who have hypertension who are at a worse chance of surviving. And then there's also another indirect link. Those who are actually recovering from a hypertensive crisis do not have access for care based on the crowding of the facilities, like a facility in Ghana, in Kumasi, Kompanoche. Next. Next, please. Next. Okay. Next. Yeah, so COVID-19's impact is the potential to give unreliable attention to those who are already having to deal with hypertension. And Vital Ranger is a simple solution to simply transform the manual monitoring of hypertensives to a digital platform. Next. Next. So the way it works is people go online to open an account. They enter results of hypertensive, and their blood pressures, and then they choose the physician or hospital that is already registered. And then they can also make payments. Next.
Okay, 1 minute warning.
Yeah. So they can do this through the USSD, or what we call the YAM phone, mobile apps, web app, or through WhatsApp bots. You know, WhatsApp started something for WHO recently. Next. Next. So this is my final slide. We want, no, go back, please. Go back, please. So we are targeting people who are already in a program for financial inclusion where they don't access cash, in that they are using digital means to have health care. And we want to take 1,000 of these people who are pregnant women to run this program readily. And
Time up.
Can scale.
Time up, sorry, time up.
Yeah.
I'm concerned about the well-being of patients when we, especially pregnant hypertensive patients, being treated or managed through a web application that aren't too compromising on the safety and management of the patients?
No, in that we have the management of these hypertensive patients, being that they go back for what we call a profile, a blood pressure profile, and they write this information on a sheet of paper, maybe 3 times a week, and bring it back to us. So we are simply digitizing this process because the digital service is more dependable. So we are not tampering with actual care that they have. We are just making it more efficient by digitizing the process.
Okay.
Okay, guys, we're very sorry that somebody's really trying to mess with our presentations. So, but I think I've addressed it with a security setting. And so I'm gonna now have Shovix go back to his screen to share.
Hi, Shovik. Would we be able to get access for the presentation? Hello, can you hear me?
Is this iHealth Africa team?
Yes, can you hear me?
I can hear you, Malvika.
Yeah, would I be able to get access to the presentation? Like moving the slides along?
Okay, let me try that. If it doesn't work, I will.
Yeah, for sure, no worries.
Yeah, can you try?
Okay, yes.
Okay.
Thank you.
Judges, are we ready for the next team, track E29?
Yes. Yes.
Thank you.
Okay, this time starts now.
Dear judges, I'm Malvika, and my team includes Wisdom, Mitra, Nikita, and Angebe, as well as an army of mentors behind us, and together we are Team iHealth Africa, a diverse group of consultants from 6 different countries around the world. We are here today to ask you to join us in launching what we believe is an innovative and equitable product to sustain primary healthcare during and after COVID-19. So what is the problem? The reallocation of health facilities due to COVID-19 has disrupted the continuity of primary healthcare with the potential of increasing avoidable deaths. This has presented a need to sustain current healthcare needs. But also, it has created a window of opportunity for us to strengthen the health system. Using telemedicine, we can create a solution that is sustainable, equitable, and adaptable not just to the pandemic, but also moving into the future. While our model can be applied to other primary health needs and contexts, we hope to pilot it for maternal and child healthcare in Ghana, Africa, owing to the team's regional expertise and recognizing a need to improve MNCH continuum of care. So what would this look like in real life? The first phase of our project will involve putting together a community health database that will include primary key indicators by partnering with local health centers and district-level hospitals. The app would then use this data to create routine appointments and schedules and send out SMS reminders to those with the phone. To expand coverage, we will mobilize local community care teams to provide inpatient reminders when phones are not available. Prior to the appointment, community health workers can use in-app telementoring trainings set up in partnership with Project ECHO, a virtual immersion training platform to connect groups of community providers with specialists. They can also use app-based telementoring to guide any questions or concerns that come up during appointments. Finally, by syncing data stored to the district health information systems, we can integrate this app into the current health system and strengthen national records and registration.
1 minute.
To think through this model, we created a comprehensive impact model which will guide our theory of change and use stakeholder input and partner engagement to ensure that this is an iterative project. We also use this to create a preliminary budget for creating the app in country. All this to say that we truly believe in this app. We believe that it can help reduce mortality and morbidity due to MNCH or other primary healthcare complications that arise due to COVID-19 health system disruptions. And we believe that our app can create a sustainable impact if you can let it be your app as well. Together, join us and let us launch iHealth Africa. Thank you. We're open to questions now. Just to keep technical issues at bay, I'll be relaying the questions, but my team is available on chat to be sending answers as well.
Thank you for the presentation. Can you talk a little bit about how the app will reduce mortality from COVID?
Mm-hmm. So one of the key issues that we found during our research, but also talking to mentors who are working in the field, is that because of the reallocation of health facilities, one, due to COVID, there's been, a disruption in primary healthcare services, but also that there's a lot of fear and stigma with accessing healthcare right now because of, the COVID pandemic and the related fear that comes with it. So instead of having patients go to the health facility, we're we're integrating the facility-based health providers so that we can get care to the patients instead. And using telementoring, we're also reducing the stress on the facility providers and instead mobilizing community health workers who are already trusted in these communities. And we're also going to do some community engagement before we formally launch this product so that the community is more aware of what's going on as well. And I can real quick show you our impact model, which has considered this using what our inputs are, what activities we'll follow at which phase, and how that's going to eventually lead to the impact. So through increased coverage of primary healthcare for at-risk MNCH patients, as well as improved quality through telementoring and teleconsultation, we hope to improve the mortality and morbidity related to MNCH. So unavoidable deaths like not being able to go to the health facility and missing a complication that could have otherwise been identified. Does that answer your question?
Thank you. Thank you.
And we're also hoping to partner with other organizations to expand this once we pilot this. So we've spoken to a couple of different partners.
Okay, thank you. Thank you, Malvika and team, for the presentation. We'll move on to the next team.
All right.
So next team will be eye boosters, E003, and following that will be Lifeline. Judges, are we ready?
Yes.
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 Okay, thank you. Who is presenting from eye boosters? Is it Emmanuel?
Hello?
Hello?
Yes.
I can see Emmanuel's hand is raised.
Yes, this is Mkize. So I'm not sure whether Emmanuel is near the phone because.
Yes,
okay, good. Good, my colleague.
Okay, so Emmanuel, just tell me whenever I need to change the slide. Just tell slide and I'll change it for you. And are you there?
Yes, I'm there.
Okay, awesome. So Emmanuel, your 3 minutes start now.
Okay, our goal is to boost the immune system. We've got a diverse team from all corners of Africa. And we've identified a couple of problems. Although Africa is not unique to pandemics, we've had Ebola, HIV, AIDS, and currently COVID. We don't know what's going to hit us tomorrow. Our current median age in the continent is 20. And this has also pressured our patient-doctor ratio to be 1:5,000. Despite the GDP to be growing at 3.75%, our healthcare infrastructure cannot cope. Slide. There's an African proverb that says that a fruit does not fall far from the tree. So, next slide, please. There's an African proverb that says a fruit does not fall far from the tree. So, given that, we have decided to hack the human mind, not necessarily create an app or a web solution. And our initial hypothesis was to create smart water purification plants. Although after a mind mapping, we realized that there is more than, sorry, I think your slides are moving too fast and I haven't seen slide yet. Back slide, please. Yes. After a mind mapping, we decided that we can enhance the immune system through encouraging our members to go to the gym and eat healthy, live a stress-free life, and go for health checks, and cut on alcohol and smoking, as well as educate themselves about their health position. Slide, please. But however, for these, for our community to adopt this, they need to be incentivized by cash rewards. We looked introspectively in how we spend our money on a month-on-month basis, and our approach would be to approach these companies to seek a 10% discount on the offering, and then we would gamify the process to our members. Next slide, please. Of course, next slide. Of course, the most productive members will gain 50%, as well as the less productive or the less engaged members will gain 5%. We remain indebted to our members in helping them live a better, healthy lifestyle by rewarding them for an active and healthy lifestyle. Next slide, please. Last slide. Next slide, please. Yes, and Harvard has said that by increasing the immune system and a healthy lifestyle can increase life expectancy by 12 years, as well as 14 years for women, as well as reduce morbidity in cancer and risks in diabetes, as well as obesity. And this will bring about some relief in our economic fiscal. Next slide, please. As eye boosters, I'm happy to take any more questions that you may have, and I is for immune boosters.
Okay, my question is, how will you implement this, especially with lockdowns and with companies closed and gyms not working?
Okay, there are various apps that are available that are looking for clientele currently, and most of them are dormant. So it's a matter of having to partner with people are still spending money in supermarkets, in travel. Uber is still functional, and people always need food and groceries. So our partner retailers will be able to give our members these discounts that they need, despite the lockdown being implemented.
Okay.
Sorry, if I may, this is Afam. I'm a team member for iBoosters. During the lockdown, we've seen that a lot of people are in their homes just sitting and eating and getting obese. I believe this is the right time to actually reach them, to start, physical activities, going to do home service kind of exercises to keep them fit and keep them healthy. And they shouldn't just eat junk, they should eat healthily and balanced diet so as to keep their body immune system ready to fight any infection or outbreaks. Thank you.
And it's a non-technology application. We're trying to hack the human mind using behavioral science and nudges that encourage a healthy lifestyle.
Okay, I think thank you for the presentation, Team iBoosters. We'll give our judges a moment. The next team to present is Lifeline, followed by Health for All.
We just presented.
Sorry?
It's me, Anand, from Lifeline.
Yeah.
So can you give me the access?
I can. Okay, Anand, I'll give you access for the slides.
Ready?
Okay. Anand, just your 3 minutes will start now. Go ahead.
Good afternoon, everyone. Our team is focusing on other side of for the current scenario. That is, currently, the whole world is facing a very big problem for coronavirus. Hello?
Yeah, we can hear you. Go ahead.
Actually, the slide is changed. Can you come again from first? Actually, we have modified the slides.
But this is what we have, what you submitted with.
Okay. Shall I start it from first, please?
Okay. Your time starts now. Go ahead.
Okay. Good afternoon, everyone. Our team is focusing on the other side of the world for the current scenario. So currently, whole world is facing a lot of problem. Next, please. problem with the COVID-19 patients, and whole hospital is filled with positive cases in coronavirus. Our problem is to find out how we can take care about the non-COVID patients and how safe we can measure and treat them. Next, please. So our main aim is to develop a product. So this is the gloves. This gloves will be attached with the various kind of sensors like pulse oximeter, heart rate sensor, temperature sensor, along with Arduino, which will detect the vital signs for the alarm system. We will include Wi-Fi or Bluetooth model depending on the situation. This product will be linked with the app, and this app will be divided into two sections, the patient info section and the emergency section. The patient info section will contain the reading of vital signs, and emergency section will include emergency transportation and a service like cab or ambulance and near to the COVID hospitals or the patients. Next slide, please. This is a working model. Next slide, please. And we also made a model of the app, and these are the screenshot of that app. Next slide, please. And this is a small pilot scale working model, which we already done in a small scale. Next slide, please. So when it comes to the market strategy, in order to tackle the competitors, we have a various kind of features like a real-time availability, 24 hours availability, contact with doctors, service working and service and other services. Next slide, please. For collaborators, we are going to collaborate with the government, contact private players and also NGOs. Next slide, please. Based on all this, we have made a small animation video. This will give you the detail about our project. Next slide, please. And here are the diverse team which worked in this project. Thank you very much.
Thank you, Anand. Judges.
Sorry, did I see you right? You had a glove. Is that the app?
Yeah, glove is a product.
Hello, ma'am. Actually, we will develop a IoT-based product which will connect all the sensors and which will measure the vital signs, and we will embed this device into the glove.
Okay, I get that. But are you going to make the glove then available in all these facilities?
Yeah. Yes.
I see.
Because this gloves will be used.
Because it's more cheaper rather than we were thinking about the wristwatches and all, but this is more cheaper.
And the glove then belongs to the patient?
Yeah, the glove will, the patients will wear the glove, which will be embedded with various kind of sensors that will measure the various vital signs.
Sorry to
And
interrupt.
the patient does not own the glove. It belongs to the facility.
No.
Yeah.
Actually, we are planning to make a market of this gloves. So the estimated cost is less than $20. That's why it is accessible to everyone to buy from the markets. Can you understand, ma'am?
Yes, thank you for that information.
Thank you.
Is there any more question?
There is no question. Thank you everyone for giving this opportunity.
Thank you, team, for the presentation. Okay, it seems like we are in for the last team.
Yeah.
Ari?
Can you hear me?
Yeah, Michael, we can hear you. We'll just start in a moment once our judges are ready.
No worries.
Yes.
Yes.
Ready.
Okay. So, Michael, are you presenting?
Yeah, I'm presenting.
Okay.
Yeah, I'm ready.
Okay.
Slide.
Just a moment. Yeah, your time starts now.
Slide. This is Kenyan Jui. He's a deaf-blind Kenyan, and the only means of communication he has is by Braille. However, most of the information about the COVID-19 and other diseases is through audiovisual media. This is Wangeshi. She's physically handicapped. She can't move, and she needs physical assistance for her day-to-day activities. However, due to the social distancing, this is a challenge. Caregivers cannot afford health services, and they, at this time, they travel slightly. This affects 300 million people in Africa, and most of them are in Eastern and Southern Africa, and that is where we're focusing on. Slide. The first thing we need to do is identify the people with disabilities. We can do this by asking the community leaders and the community health workers to enroll the people with disabilities. After that, the community leaders can mobilize the community to actually help the people with disabilities. They can do this, as you can see in the picture, by making sanitizers, liquid soap, and face masks by local things. Slide. We can actually see, we can use methylated spirit and glycerin to make 1 liter of sanitizer for $1, and we can make liquid soap 20 liters for just $8. After that, you can provide training to the caregivers to help them take care of them. And then we can use an app to link the caregivers, the disabled, and the health workers, and to translate across all platforms, especially for the deaf who only understand American Sign Language. Next. Who will pay for this? The government can offer funds and resources. In the hospitals, they can put interpreters. The Ministry of Education can provide information in Braille for the people with disabilities. And then we can have NGOs and investors who can actually partner with us. Next. Slide. So for this, we want to start with Zambia as a pilot. The reason for this is one of our members already has
1 minute.
Already has experience working with organizations dealing with the disabled. And after that, we want to scale up to 10 countries in Eastern and Southern Africa as soon as possible. As we know, as the pandemic increases, the global health inequalities also widen. By December 2020, we can start selling and packaging soap and sanitizers. This will help to actually pay for our initiative and also to financially empower the caregivers and those with disabilities. And after that, we can collect data. We know who has disabilities, where they are, and what disabilities they have. And that can help create registries for people with disasters. And we can sell that to country governments and international organizations. Thank you. If there are any questions, we can take them.
Yeah, thank you. Can you please expand on how this directly ties to disability and the question of equity?
People with disabilities are actually, globally, they're actually the largest group of minorities. And even without the COVID-19, they have very difficulty accessing health services. And now, especially with this, it's even actually worse. And the gap is actually there. To transport them there, social distancing is bringing such a big issue to that. And sometimes there can be the issue of discrimination, especially in hospital, and lack of communication, as if they understand sign language and the doctor doesn't, there is no healthcare that they will receive from the doctors. They cannot communicate.
Shavik, are you there?
Yeah, I'm still there.
Hey.
Okay. Yes? I beg your pardon?
Do you have any more questions?
I'm good, thank you.
Okay, thank you, team. Thank you for the presentation.
Thank you too.
Yeah, I think we have finished all the presentations. I'll just go to the chat room. So all the participants, I think the next thing that you have on calendar is the final announcement or the presentation that will happen at 3. You have a different link. I guess all of you have access to that. If not, we'll post that link again just in some time on the track channel, but we'll see you there. But thank you so much for putting up so much of effort over the last 2 days. And before moving out of this Zoom room, I just urge the judges to share their their thoughts, their comments on all the presentations put together, and then we'll get back to the big webinar room to announce who are the top 3 teams from track E.
I also just wanted to quickly comment that I want to congratulate everyone. This has been a crazy weekend. We're coordinating this 1,500 person hackathon across so many different time zones. And it's just been an incredible effort by everyone to work so hard on making something happen in a very short amount of time. And what you've all come up with, every team, what you've all come up with, I think has just been incredible with the short amount of time we've had. I think we've all trying to been navigating Slack and Zoom. It seems like we even had I had my first experience with a Zoom bomber today, somebody writing on people's presentations. Crazy. Anyway, I just wanted to congratulate everyone and just thank you all for participating and bringing so much energy and thoughtfulness to all the work that you were doing today and for the last 2 days. And whether you win a prize or not, I just wanted you all to feel like you really accomplished something this weekend, because you really did. And you've helped us also understand a model for virtual hackathons going forward. So thank you again from me and from everyone else in the team. It's been a pleasure working with all of you.
Judges, if you want to share just a high level thing that you saw from all the teams put together, and then we'll move to the figuring out the scores and things.
Yeah, I also want to say congratulations to all of you. I think this was really exciting, and you all had really relevant and important innovative presentations, and things that are really practical beyond this that could be used in so many countries. So well done to all of you for all the hard work, and also for the enthusiasm and excitement in the way that you presented your work.
Yeah, I think this has been a very exciting afternoon for me. It's very exciting to hear all these various innovations and the different angles from which they come, realizing that it's all been achieved in the space of just a few days. So there's a lot of potential for us to see great things coming out of this COVID-19 adversity. So thank you for all the presentations and the hard work. And thank you for inviting me to be a part of the panel.
Yeah, just to echo my fellow judges, thank you for all your efforts. And I personally learned quite a lot about Sub-Saharan Africa through your presentations.
I think those were really encouraging words from our judges, and as participants, as you can see, like they have wealth of experience from all different parts of the society that we live in, and their work, not just focusing on Africa, but their experience across the globe. That means a lot for all the participants, and also to judges. I think we're just surprised and excited up to how much this team all the teams have been able to deliver within, I would say, although we say 2 days, but it's literally a day maybe, especially for people who didn't know each other to begin with, coming together virtually, not even in person, and just to share common experience or common interests and just form a team and work on some idea and bring that to some stage within a day or day and a half. I think we are super excited, and as Audrey mentioned, like we as organizers learned a lot during the process. I'm sure there were issues, there were concerns, and there were some, I'm sure everyone faced some issue or the other. We're sorry for that, but we really hope that you take this experience forward and not end here. The team, the idea that you already have, that you presented, I think that has a lot of potential. Our team will be in touch with you for post-hackathon, you know, all the resources that will be made available to users that you can work on these ideas and take them forward. And just wish that we all come out of this situation better, and through the solution, through the applications that you are building, hopefully we will end the COVID-19 crisis faster than otherwise it would be. That is all that I had to say. And as a track lead, I'm extremely privileged, and thank you for all the efforts that all of you put in. Thank you so much. Okay, so should we move out of this? Ari, is there anything else you want to mention?
The participants can all leave the room, and we'll just briefly connect with the judges.